It's my job now to explain to you randomized controlled trials. We already heard several things about it. You will have heard some things which I will show you. I will try to summarize so you get a clear perspective what a randomized controlled trial is. The first randomized controlled trial was already performed in 1948 with a very well-known co-author, Austin Bradford Hill, which, for example, is famous for finding the association between lung cancer and smoking. Randomized controlled trials are the gold standard to investigate the effect of an intervention. Meanwhile, randomized, once more, means equal chance of being allocated to a treatment group, and controlled means that the new intervention is compared either to a standard treatment if there exists a standard treatment or placebo. These are the learning objectives. We'll talk about the control group, about randomization, about blinding, about variations in trial design, and about study reporting. The control group must be comparable to the intervention group in all relevant aspects except for the treatment of interest. Comparable means, for example, being similar on average for age, gender distribution, etc. Otherwise, the comparison is biased and not reliable. If we have a control group, this allows to draw a conclusion about a causal relationship between treatment and outcome. So if we don't have any control group, we cannot be sure if really we find an association, this is really a causal relationship. The new intervention is either compared to a standard treatment, as we have already told. That's when a treatment is already in routine use, or a placebo when there's no standard treatment. We are not sure whether the new treatment is better than no treatment. Sometimes it is difficult to decide what the control gets, what treatment the control group gets. That's called equipoise, which means that there's an uncertainty about the benefit of one treatment compared to the other treatment. Otherwise, it's not ethically to compare two different treatments. There's sometimes difficult decisions to decide about the standard treatment. For example, the Harvard study was about blood pressure lowering therapy in patients over 80 years. It was published in 2008, and surprisingly, the control group just got placebo. So because there were no data showing that there is really a benefit to lower the blood pressure in patients over 80. It's surprising, but these were the data at this time, so they decided it's okay to compare to placebo. And it was very positive, the study. So blood pressure lowering is a very good thing to do in patients over 80 years. Another difficult decision, for example, is the reverse AD study. It's about antagonization of dabigatran with the specific antibody idarucizumab in emergent situations. And there the final decision was not to have any control group because it was felt that it's not ethically to withhold any antagonization in emergency situations. Randomization, once more, means random allocation of participants to treatment arm. It's like tossing a coin. Usually it's done by a computerized random number generator. Today, each participant has, by randomization, a known chance. Usually it's 50% if there are two equal size groups of being allocated to a treatment group. If you have an equal group size, you have also the maximized statistical power. And neither the investigator nor the participant can influence or predict the allocation. That's very important that you have a correct allocation. The advantages, we have already talked about this, of randomization is if you have correct randomization, it ensures comparability of the treatment groups, it avoids allocation bias, and groups will be similar in all aspects except for the treatment, and it controls for known and unknown confounders. That's a difference to observational trials. There are different methods of randomization. There's the simple randomization, which means just one patient after the other is randomized to one group. This may result in relevant imbalances, particularly in small studies with regard to baseline characteristics, number of participants assigned to treatment. There are specific methods of randomization to avoid these imbalances. One is block randomization, which ensures that there's an equal distribution within a block of patients. We will see how it works soon. And stratified randomization, this ensures equal distribution in relevant patient subgroups. So each subgroup is randomized separately. Here we see how block randomization works. The blocks are randomly allocated, and in each block we have the same number of treatment allocations. So for example, if we have a block size of 4, we see here the possible combinations, and the important thing is all have the same number of AAs and BBs. So we have ensured that after this block, the same number of patients get the same number of treatments. Stratified randomization means that we separately randomize in relevant strata, for example in each strata, and stratified randomization prevents imbalances in relevant subgroups. And you can also do block randomization in the subgroups. This makes sense. Here we have a very recent example. That's the BEST trial, which has been now presented at the ACC and is published in the New England Journal of Medicine. It compared everolimus-eluting stents compared to bypass surgery, and their randomization was computer-generated and was performed in random block sizes of 6 and 8 with stratification according to the participating center. So they had participating centers in several countries and wanted to ensure that really the treatment distribution is equal in each center. Let's move to blinding. Blinding means masking the identity of the treatment. There are different ways of blinding. Single blinded means usually only the patient is blinded. For example, this is common for surgical interventions. Double blinded means neither the investigator nor the participant are aware of the allocated treatment. For example, this is common for pharmacotherapy. And sometimes you also hear the word triple blinded, which means that additionally the endpoint evaluation committee is blinded. How do we blind? We need a placebo. This can be a dummy remedy, for example, a pill with same size and color and aspects as the true intervention. We need a double dummy design for blinding when we compare two interventions with different aspects. So each patient receives a true intervention and an indistinguishable dummy for the other treatment. And another way of blinding is the sham operation, which could include anesthesia and even incision. What's the advantages of blinding? It avoids the placebo effect. The placebo effect means that we have a response to the medical intervention which results from the intervention itself and not from the specific mechanism of the intervention. Masking of the participant avoids reporting bias. So the participant may report an event differently based on his beliefs and his knowledge. This is not consciously, but usually unconsciously that he reports it differently. Masking of the researcher avoids observation bias based on the beliefs about the treatment. Also, the researcher may unconsciously perceive events differently. And that's a very important point. Blinding also avoids compensatory treatment. So if the doctor knows that the patient is in a certain group and he thinks this treatment is not good, he may give some additional treatment, for example, another antithrombotic therapy or something because he doesn't believe in the treatment. So this is avoided by blinding. Here we have an example, the Simplicity Hypertension 3 study. There have been prior unblinded studies before about renal artery denervation, and they have been positive, showing a reduction of blood pressure in patients with resistant hypertension. And the Simplicity Hypertension 3 study was a prospective single-blind study, so the patient was blinded, was randomized, and it was sham-controlled. The primary efficacy endpoint was the change in office systolic blood pressure 6 months, and the secondary efficacy endpoint was the change in mean 24-hour ambulatory systolic blood pressure. Here we see the results, and surprisingly, there was no difference. If you look here, we have on the left side the office blood pressure. We see a change of 40 millimeter with denervation, but we also see a reduction of 12 millimeter with the sham operation. So obviously there was a great placebo effect of the sham operation, and there was no significant difference. If you look at the ambulatory 24-hour blood pressure, there was a difference between the start of the study and after the intervention was even lower. So obviously the more objective measurement with ambulatory 24-hour blood pressure measurement even showed less difference or less effect, which indicates that there may be really a placebo effect. And there was no difference at all between the two groups. So what can we learn from the Simplicity Hypertension 3 trial? A sham procedure, if ethically acceptable, is essential to distinguish between the placebo effect and the effect of surgical intervention. Blinding is essential when assessing the effect of an intervention on blood pressure. And another thing which I didn't discuss and now is enrollment of highly selected patients. For example, resistant hypertension is challenging, and there are a lot of troubles and challenges to find the patients who really were resistant to antihypertensive drugs. With regard to blinding, there's another specific design, the so-called probe design. Probe means prospective, randomized, open label, so not blinded, but blinded with regard to endpoint evaluation. So this is the probe design. The probe design is used when double blinding is very difficult or too complex. For example, for laboratory guided treatment, if the intervention has some characteristic side effects, so it's easy to find out what the patient took, or if it's a device study. The advantage is, if you do this study and you don't have a very complex study procedure, you avoid that this complex study procedure may increase the likelihood of selecting particularly compliant patients who are able to follow very complex study design, and you also avoid study discontinuation of participants due to the complex study design. The probe design has been used for the REALIZE study. REALIZE study compared dabigatran to warfarin. What was the rationale for the use in an anticoagulation trial? The laboratory-guided treatment of vitamin K antagonist in a control group, including sham INR measurements, requires a very complex blinding. So this was the reason why they did the probe design. Blinded study design may have also led to frequent and uncontrolled unblinding when measuring global coagulation tests. So it was very easy for the doctor to find out by global coagulation test if the patient was on the true treatment. To minimize a potential investigator bias, they had several safeguards in the study. Outcomes were objective, outcome events were adjudicated by a blinded adjudication committee, and doses of dabigatran, there were 2 different doses, were blinded. Here, let me compare once more advantages and disadvantages of a probe design compared to a double dummy design. The advantages is more economic, it's less complex and therefore more similar to clinical routine and has a lower dropout rate. The disadvantages is I have a risk of a reporting bias because the patients know what they take, and a blinded endpoint committee can only evaluate endpoints which have been reported. So they cannot find out any endpoints which have not been reported. Okay, we move on with variations in trial design. There are 2 possibilities. On the left side, we have the usually used parallel group design, which means Group A receives the blue treatment, Group B receives the red treatment. On the other side, we have a crossover design, which means Group A first receives the red treatment and then the blue treatment. On the other side, Group B first receives the blue treatment and then the red treatment. Usually, there's a washout period between to avoid any carryover effects of one of the treatments. There's one major advantage of a crossover design. You need a smaller sample size as there is no between subject variability, so each participant is his own control and therefore the variability is lower. There's disadvantages. You cannot use it for acute treatment. You can only use it for temporary treatment. You have also always to question, is the washout period reliable or are there carryover effects? And patients are completely lost if a dropout occurs before the second treatment. So if you finished one phase but not the second, you have to take out the patient. We already heard today about the factorial design. Giuseppe already told us about. It allows testing more than one hypothesis in one study, so it increases the efficiency of research. Usually you have a 2x2 factorial design. We have, for example, for a 2x2 factorial design, 4 groups. One group receives treatment B, one group receives no treatment, one group receives both treatments, and one group receives treatment A. Here we see an example, that's the Fuse MI study. Here an aspiration catheter was tested, and in addition also the intracoronary infusion of abciximab was tested. The important thing about the study design is interaction. You should be aware of if these 2 treatments could have some interaction, you should test for interaction between the 2 treatments. So either you do 2x2 factorial design with 2 treatments which have nothing to do at all, like candesartan and statin, as we heard in the morning, or you do something which in this study where there may be some interaction between the 2 interventions, so between abciximab and the aspiration catheter. They checked and there was no significant interaction in this example. So the advantages of a factorial design: you need a smaller sample size than for 2 separate trials. You can assess the interaction, which is the modification of the effect of one treatment by the other treatment. The disadvantages, there's added complexity, and the chance of adverse effects, of course, increases if you test 2 drugs. So finally, let's look at the study reporting. There is a standard for reporting of randomized controlled trials. That's the so-called CONSORT statement. There are also other statements for other studies, like the strobe statement, which is not so well known for observational trials. It gives the gold standard how to report and therefore already design your clinical study. One of the recommended things is to have a study flow. So you should clearly show the patients, how many patients were assessed, how many patients finally were randomized, and what happened with the patients after randomization, and how many patients were finally included. If you do an intention to treat analysis, then all patients should be analyzed. And here we have a list, there's a checklist where you can find all the things you should report. Sorry, it's rather small. For example, you should tell about the trial design, if it's parallel, factorial design. You should tell about the eligibility criteria for participants. You should mention the intervention, the outcomes, how the sample size was assessed, how randomization was done, and methods to use to generate the random allocation sequence. You should also report, for example, blinding, how patients, if and how patients were blinding, your statistical methods. So you have a whole checklist, and you should check this before you start with the study to make sure that you really can answer all these points afterwards. Let me summarize the advantages and then also the disadvantages of a randomized controlled trial. The advantages is randomization avoids selection bias and controls for known and unknown confounders. Double blinding avoids reporting bias and observation bias. And the analysis of randomized controlled trials gives strong evidence of a causal relationship and multiple outcomes can be examined. The disadvantages of a randomized controlled trial, they are expensive and require a large study team, data restricted for several years because the study usually needs very long time. External validity may be limited. For example, if there's a volunteer bias, so you only find patients which are very compliant and not typical for the general patient. If there are restrictions to geographical areas, so if you not have done your study in the whole world. If there's sometimes complex study examination which are not used in routine. There may also sometimes, we already discussed it, rather odd composite endpoints which are not used in clinical practice or not clinically relevant, or there's incomplete reporting of adverse events. And finally, you always have to ask, is it ethically to randomize? So is there equipoise of treatments, which means you don't withhold a beneficial treatment and you do not allocate a harmful treatment. Thank you for your attention.